Hello guys, my name is Dr. K Dodiya. I'm an MBBS graduate from UV GCM Philippines in 2024 and I successfully cleared my FMGE with first attempt by getting score of 195. So in this video, I'm going to share one image that helped me get 3 questions correct and it's going to help you as well. So with the purpose of that, let's start with this. The topic will be on renal physio, pharma, patho and medicine integrated. So starting with our kidney, each kidney is having 1 million nephron, a total of 2 million nephrons, and in these kidneys we have this middle space. It's called as renal column of Bertini as it's marked here. Then we have minor calyx, we have major calyx, we have renal pelvis, and this thing is renal medullary pyramid. The tip of it will be renal papilla and the space between will be renal column of Bertini, outer cortex, inner medulla. So let's get started towards the nephron, which is the functional unit. So as we know, it has the efferent arteriole, and the tuft of capillaries called glomeruli or glomerulus collectively. Then we have the basement membrane for it. This becomes our Bowman's capsule having podocytes and the slit diaphragm or slit pores made up of nephrin and podocin. We have the PCT, descending loop of Henle, ascending loop of Henle, DCT, collecting duct, and the principal cells and intercalated cells. Each minute, our kidneys receive 1250 ml of volume or blood, out of which 45% will be cells like RBC, WBC, platelets and all, and 55% will be plasma. So 55% of 1250 is going to be 625 ml. So this 625 ml of plasma fluid, which will be going by this efferent arteriole to the glomerular capillaries, and it will be passing from this basement membrane, the slit pores, and all the PCT, loop of Henle's, DCT, and collecting duct, and it will make urine. So how? Let's get started. Now for this urine or this plasma fluid to come out from the capillaries, it has the first thing called as this fenestrated pores, and they are 4 to 8 nanometer of size. So anything between size from 4 mm to 8 nanometer are going to pass easily from this. But in plasma we also have the most abundant protein in the plasma, which is called as albumin, and albumin is the size of 8 nanometer, but it won't be passed out, it will be sent back to blood, it won't be passed out in urine. Why? Because our basement membrane is having a negative charge, so does our albumin protein having a negative charge, so this negative charge is going to repel it out, hence you won't be having albuminuria in normal conditions. Then moving next, this basement membrane, after this into the Bowman's capsule, we have podocin and nephrin coded by NPHS2 gene and NPHS1 gene. Then collectively our glomerulus and the Bowman capsule are being called as Malpighian body. These cells, like a foot process, are called as podocytes. Then the inner side is going to be visceral epithelium, outer will be the parietal epithelium. Passing from these barriers, our plasma fluid or the filtrate can be sent for the formation of urine, by where reabsorption and secretion takes place under the influence of hormones and without the hormones as well. So now there are 3 factors which affects the filtration rate. Majorly the capillary hydrostatic pressure or glomerular hydrostatic pressure which is the pressure by the flow, for which this all fluid is going to come into the Bowman capsule while crossing all the layers. This force will be 60 millimeter Hg. Then the next will be blood colloid oncotic pressure, which is due to our albumin, which will not let the filtration to happen. We can say it's going to resist filtration. Then after that, it's going to be 32 mmHg. Then we have the capsular hydrostatic pressure, which will be exerted against the filtration due to the pre-existing plasma fluid being here. So it's going to send back the excess amount that we already have enough here. We cannot take more load, so you take it back, and that will be around 18 mmHg. So total our net filter rate will be 10 mmHg by minusing 60 minus 32 minus 18. In our PCT, where the urine is isotonic, 100% of glucose and amino acids are going to be reabsorbed back into the blood, while 70% of ions like sodium, potassium, bicarbonate, calcium and chloride are going to be reabsorbed, and rest will be sent down. Afterwards, we have the SGLT2 receptor or sodium glucose link transport receptor or channels 2. Two kidneys, SGLT2. This locations of these channels also can be asked, so that's the way to remember: two kidneys, SGLT2 receptor. Now this is ATP dependent channel. Then this side of the cell where it's facing towards the PCT will be called as apical side, and which is away from it is called as basal or basolateral. Now on the basolateral side we have GLUT1 channel, which is going to transport this glucose which was reabsorbed from PCT back to blood. We also have sodium hydrogen exchanger channel here. Each time sodium ion will be reabsorbed back here, one hydrogen ion is going to be excreted out. Now the CO2 and H2 I mentioned here is from our metabolic processes. The enzyme called as carbonic anhydrase, mentioned here as Ca, this carbonic anhydrase enzyme is going to make H2CO3, and this H2CO3 is going to be split into HCO3 minus and H plus, and this H plus ion will be sent out here. Now this can also help in making our urine acidic or basic. So if more H plus ions are going to be excreted out, it's going to make our urine acidic, and that's when we are going to face some burning micturition kind of sensation. After all this happen, this isotonic urine is going to pass into the descending loop of Henle. Now this descending loop of Henle is only permeable to water and not the ions. Hence the concentration is going to be very high here, and it will be called as hypertonic urine. This hypertonic urine then will flow towards the ascending loop of Henle, where only ions are permitted to be reabsorbed, and it is having channel called as sodium potassium 2 chloride channel or sodium potassium 2 chloride symporter or NKCC channels. So once the ion goes out, this is going to make our urine hypotonic. Then this hypotonic urine will go to DCT, where DCT is having sodium chloride channels, and the sodium chloride channels are going to do its work by reabsorbing sodium chloride, and the rest amount will be sent to collecting duct. Now collecting duct will work under the influence of some hormones, and these hormones are going to act by this nucleus and their receptors, and they'll stimulate this epithelial sodium channel, aquaporin 2 channel, ROMK or renal outer medullary potassium channel. These hormones are antidiuretic hormones and aldosterone. Talking about the antidiuretic hormone first, its normal function is going to be water and urea absorption by this aquaporin 2 channels. The same antidiuretic hormone will also work on the V1 receptor, via the secondary messengers as in IP3 or DHE or releasing calcium. It will cause vasoconstriction and it can alter the renal filtration rate. It can make urine hypertonic by doing vasoconstriction and the urine volume will be low. These V1 receptors are situated on efferent and efferent arterioles. And our aldosterone is going to reabsorb sodium via epithelial sodium channels. Now along with sodium, wherever sodium goes, water follows. So sodium and water are going to be reabsorbed, and when that happens, potassium and hydrogen are going to be excreted out. After this physiology portion, let's move towards the defects. So first starting with our podocyte having slit pore. Now the slit pores are made up of nephrin and podocin. So if this nephrin, which is coded by NPHS1 gene, if it's get defected, it's with this effect are going to have congenital nephrotic syndrome. If NPHS2 gene getting defected, which is the coder of podocin, then the person will suffer from steroid resistant nephrotic syndrome, which means that the person is going to still lose protein into urine even though giving steroid treatments. Let's move towards some other disorders in the below diagram. So after that, now if the apical side of the cell getting damaged due to any reason, then this SGLT2 channel, the sodium hydrogen exchanger channel are not going to be functional. Now when that happens, glucose will be going out. Now this PCT is also taking water in, or other ions which are 70% will be reabsorbed back. So all those are going to be excreted out. So we will have glucose-urea, amino acid urea, phosphate wasting will happen, metabolic acidosis will happen, because the sodium ion is not going to be excreted out. It will stay within our system and it will give acidosis and dehydration, because water also is not going to be reabsorbed from the PCT portion, and amino acid urea. Based upon the function of carbonic anhydrase and the H ion excretion, we have a disease associated with that, which is mountain sickness. What happens in this sickness is, when we go into higher altitudes like on trekking or mountain climbing, there is less oxygen concentration in the air as well as in our body, due to which, to compensate less oxygen concentration in our blood, our body will try to breathe faster by doing hyperventilation. This hyperventilation will lead to more carbon dioxide getting excreted by our breath, or CO2 washout. The CO2 washout will give us respiratory alkalosis. This will lead to decrease in the blood pH. Now that's another problem. To compensate that problem, our kidneys will reply by excreting out more of bicarbonate ion. So when this H2CO3 will get excreted out, we will have alkaline urine. This will lead to alkalis getting excreted out and less alkalis in our blood. So it will bring back the pH again back to normal by making it metabolic acidosis. But if our body is not sufficient, or our body is not working sufficiently, or not able to compensate the change in the environment, then we have a drug called acetazolamide, which is a carbonic anhydrase inhibitor. This drug will stop the formation of H2CO3 and it will promote sodium and water loss, because sodium can come in only when the hydrogen is there to be excreted out, but there is no hydrogen to be excreted out, so the sodium is going to be wasted, and along with sodium some of this bicarbonate will also be excreted out, so it will make our urine alkaline and our blood pH acidic as a side effect. So the side effect of this drug is going to be metabolic acidosis, which is required to maintain the blood pH, which becomes alkaline in mountain sickness. So we can use this drug, and this was the FMGE Jan 2025 physiology question from this diagram. This is a screenshot from the Miss YouTube channel. The question was that a 30-year-old woman going to mountain area for trekking. She suffers headache and nausea like symptoms. She takes a drug to improve the symptoms. Identify where this drug will act on the nephron. Now, I'm not able to recall if they give this diagram or not, but what I have told before, that this drug is going to act on PCT, where we have this carbonic anhydrase and the sodium hydrogen importer channels and all. So this drug, the thing they talked about here was mountain sickness. So by the symptoms and the history, that mountain trekking, headache, nausea, which happens due to our respiratory alkalosis. And so that was our diagnosis first, that was mountain sickness. Then drug which she used, they didn't mention the drug as well. So we know the drug that we use, that is acetazolamide, a carbonic anhydrase inhibitor. And we know now where it's going to work. So it will work on PCT. So that was the question, and the answer was proximal columnar tubule PCT. To integrate pharma also along with it, we have called drugs a class of drug which is osmotic diuretics, which is mannitol, which you will be giving in your internal medicine or in surgery to head trauma patient to decrease their intracranial pressure. So this also is going to work on this loop of Henle. Now moving forward, not effects in the descending loop of Henle, but in the ascending loop of Henle, we have a channel called the sodium potassium 2 chloride channel. Suppose if this channel gets defective, this will lead to syndrome called as Bartter syndrome. Now what will happen is that the sodium, potassium, chloride and calcium are not going to be reabsorbed back into the blood. Because of that, along with sodium, water also will follow. So it will lead to sodium and water loss or dehydration, hyponatremia, hypokalemia, hypochloremia and hypocalcemia. But in this place, our magnesium level are going to be normal. Now to integrate pharma here, we have a drug class called as loop diuretics. Now from the name we can know loop and diuretic. Diuretic means losing of sodium and water, and loop means it's working on the loop of Henle. Which loop? The ascending loop of Henle or thick ascending loop of Henle. This drug furosemide will inhibit this sodium potassium 2 chloride channel, and it will inhibit the reabsorption of all the sodium, potassium, chloride and calcium. So we will have symptoms or lab findings as of Bartter syndrome. It is having maximum vasodilatory properties because it's going to release prostaglandins. Now we know that prostaglandins will do vasodilate. So it is having maximum vasodilatory properties, and it's also drug of choice in a condition called as pulmonary edema. Apart from that, another side effect will be metabolic alkalosis, and it is ototoxic drug. Now to use this ototoxic drug, I'll integrate some ENT in here. This is a disease called as Meniere's disease. Now what this Meniere's disease is just as raised intracranial pressure, but it's in our ear, so we can say raised inner ear pressure. Now in this case we will have vertigo or hearing loss for hours, and when this things gets too worst or it goes for days, then we can use some ototoxic drug to destroy the inner ear and have relief from the symptoms. That's about the furosemide here. Let's move forward towards our DCT. In this DCT we have this channel called as sodium chloride channels. If this gets defect, we have a syndrome called as Kittelman syndrome or Chittelman syndrome. This also absorbs magnesium from here, but it has no role in calcium absorption. So if this is not going to work properly, we will have hypomagnesemia, but the calcium ion concentration is going to be similar. There will be no changes in that. To integrate pharma here, we have a drug class called as thiazide diuretics. This thiazide diuretics example can be hydrochlorothiazide. Now these are moderate efficacy diuretics and diuretic of choice in hypertension. Now it has a very unique property that it will save calcium. It will take back calcium from our urine back to the blood. So when there will be less urine in the less calcium in the urine, so what it will do is that it will not let it deposit into our urinary tract. Now if it gets deposited, it will lead to urinary stones, or it can go into kidney or our bladder or anywhere. So the good effect of this drug is going to be that it will be helpful in patients who are having renal stones or nephrolithiasis. But it has also some side effects. Some very not good side effect for males, which is going to be erectile dysfunction. But the another side effect will be similar as furosemide, that it's going to lose all the sodium, potassium and all. Moving forward, defects in our DCT, distal convoluted tubule. Now in this principal cells we have channel called as epithelial sodium channels. We have aquaporins and we have renal outer medullary potassium channels. Talking about ROMK first, if this channel starts overacting or it start to working more, then it will lose this potassium and the hydrogen more. Now if the hydrogen ions are getting excreted more, then it's going to cause our urine to be acidic and our blood to be basic, so it will lead to metabolic alkalosis and hypokalemia. Now this hypokalemia can have symptoms such as our arrhythmias and muscle weakness. Then going next towards, if the epithelial sodium channel gets defective or overactive to say, so it will give to us a syndrome called as Liddle syndrome. What will happen is that this channel will take more sodium in, more water in, and due to which this potassium and hydrogen will have to go out more. So same thing as here, we'll have hypokalemia, metabolic alkalosis because of losing more hydrogen ions. But it's also taking more sodium and water in. So it will not give us hypernatremia, because along with sodium, water is also coming in. But it will give us hypertension. To integrate pharma here, we have a drug called as ENaC blockers. This drug is amiloride. Now this drug will block these channels, so it will not absorb more sodium, more water, and it will not lose more potassium and hydrogen. So as a side effect, it can lead to metabolic acidosis and hyperkalemia, also hyponatremia if the dose gets high. Then we have problem with our hormones, starting with our antidiuretic hormone. We already studied it. Normal function of our antidiuretic hormone is going to be inhibiting sodium and water loss. Now problems with our antidiuretic hormone can be either it can be too high or too low. So for this, in condition called as diabetes insipidus, which can also happen due to lithium toxicity, and we have SIADH or syndrome of inappropriate antidiuretic hormone. In this, the antidiuretic hormone is going to be secreted too much. Now this can be due to condition called as pituitary adenoma. Now we know that this antidiuretic hormone is going to be excreted from our posterior pituitary. So if we get the odd cell carcinoma or pituitary adenoma, then we are going to have more ADH. What will happen is it will end up absorbing more sodium and more water. So the urine concentration is going to be high. Urine volume is going to be very little. Our plasma concentration will get less because there is more water absorption or reabsorption, and it will lead to dilutional hyponatremia, which means that the sodium concentration is regular or normal in our body, but due to more water reabsorption, we are having our blood diluted. So in this condition, to integrate pharma here again, we can use drug called as V2 receptor inhibitors or VABTAN drugs. This will inhibit this V2 receptor, so that no matter how high this antidiuretic hormone gets, it's not going to have its work done by the V2 receptors, and the no more sodium, water and sodium are going to be reabsorbed. So all these things as dilation and hyponatremia and all are not going to be done. Diabetes insipidus, the low concentration of antidiuretic hormone can be due to two causes. Either it can be from the brain or in the kidney. In the brain, by having a neurogenic, or if the posterior pituitary will secrete less antidiuretic hormone, or nephrogenic, where ADH is in normal concentration but renal receptors or these V2 receptors are non-functional. Now this can happen due to lithium toxicity or amphotericin B, or condition called as amyloidosis, where abnormally formed proteins are going to be deposited. Pharma portion here will be for this nephrogenic diabetes. We can stop the drug which is causing this. Next will be to correcting the electrolyte imbalance, because there will be no sodium and water being reabsorbed, so it is going to have more of our hydrogen and potassium in our body. Then we can give thiazide diuretics, which will inhibit the sodium reabsorption and it will increase the sodium loss. As a feedback mechanism, it's going to help our body. That feedback mechanism will stimulate secretion of more ADH. Now this ADH was normal only, but it was the lithium or these drugs which were the culprits here. So when the culprits are not there, then this ADH will be working whatever it's doing properly. So this thing can be solved. Next, so in our neurogenic diabetes insipidus, where ADH is coming less from the pituitary, we will be using drug called as desmopressin. Now this drug will lead to more secretion of antidiuretic hormone from posterior pituitary. Now what will be happening in this situation is that there is no ADH. No ADH, it won't be doing its normal function, which is to taking back sodium and water. So if that won't happen, there will be more water loss into urine. Then it will lead to more urine volume and less urine concentration. Opposite to it, we will have high plasma concentration, and it can also lead to hypernatremia, because water is getting lost and we will be having dehydration. Another hormone we have here, which is aldosterone, or also it's a mineralocorticoid hormone, which means it's coming from our suprarenal gland or adrenal gland. This mineralocorticoid hormone is having a mineralocorticoid receptor here in the principal cells. So if our aldosterone gets too much more or too less, then we will have to use some pharmacological intervention. So let's start with that. So for this, we have two conditions. One is Cone syndrome, where aldosterone concentration is going to be too much, and another is Addison's disease, where aldosterone concentration is going to be decreased too much. Now aldosterone, what it does is it will take back sodium and water. In this condition, Cone syndrome, where aldosterone is too much in concentration, so it's going to take more and more sodium in. As you can see here, the aldosterone function from this mineralocorticoid receptor, it will take more sodium in and more water in, and it will lead to more potassium getting excreted and more hydrogen also getting excreted. So it will lead to hypernatremia, hypokalemia, metabolic alkalosis. I have mentioned all this here, and also it's taking in too much of water also. So we also will have hypervolemia, hypertension, and as mentioned, metabolic alkalosis. Now this syndrome can happen due to adrenal adenoma secreting aldosterone. Now to stop this or to get relief from this, we can give drug called as spironolactone, which is also known as a famously potassium sparing diuretic. What it will do is it will inhibit this aldosterone receptors on the collecting duct. Now it will inhibit this MRA or mineralocorticoid receptor antagonist. So all this overactivity of this ENaC channel and this potassium channel, hydrogen channel due to aldosterone influence are going to be decreased, and the symptoms will be less. Then, what if this aldosterone gets too low, as in Addison's disease? This will lead to opposite of what was there in the Conn syndrome. We had here hypernatremia because of more aldosterone. So here there is less aldosterone, less sodium reabsorption, more potassium excretion, less volume, less blood pressure, and metabolic acidosis because less sodium is getting taken in, so no more hydrogen is getting excreted out. So more hydrogen in the blood, it will give us metabolic acidosis. For this metabolic acidosis or this Addison's disease, we can give hormone replacement therapy, and also we have to correct the electrolyte imbalance. Now, as mentioned earlier, the drug amiloride, which was being used as ionic channel blocker, which is also a potassium sparing diuretic. From this, we also had another two questions. So the first question was, a hypertensive patient's lab results revealed hypernatremia, hypokalemia, and metabolic alkalosis. Does this sound familiar? Yes, it does. We just studied it, and it's just beside, which is a Conn syndrome lab findings, as it's having hypernatremia. We have hypernatremia, hypokalemia, and metabolic alkalosis. And the options were Addison's disease, Conn syndrome, Bartter syndrome, and Chitoran syndrome. Now in Addison's disease, which is opposite to Conn syndrome, we won't have metabolic alkalosis or hypernatremia. We will have hyponatremia and metabolic acidosis. So here, this option gets ruled out. But in Bartter syndrome and in Gitelman syndrome, we do have hypokalemia and metabolic alkalosis. But patient is also hypertensive, which is also a symptom here, and which won't be in Bartter and Gitelman syndrome. And also the hypernatremia, which is a function of, or which is the evil side or the bad effect of more aldosterone. The another question was that which segment of nephron has the lowest osmolality under the influence of antidiuretic hormone. Now, lowest osmolality, which means they are saying that the urine is diluted. In which portion of the nephron urine will be diluted? So, as we discussed earlier in the physiology portion or physiology part here, that urine is going to be isotonic in PCT, descending loop it's going to be hypertonic, here it's going to be hypotonic, which means urine concentration is going to be low, or osmolality is going to be low in the ascending loop of Henle and DCT. And also the aldosterone and antidiuretic hormone, these both hormones are working in the DCT more, in the collecting duct more, and not on the DCT. So we had options as early distal tubule, late distal tubule, descending loop of Henle, which is here, and collecting duct. Now, lowest osmolality, which means less concentration. Now, just think guys, we just studied before, if we have more of antidiuretic hormone, will it lead to have our urine diluted? Of course not. It's going to give more osmolality. It will give higher osmolality, higher concentration. So the collecting duct cannot be the answer here. Now this early distal tubule and late distal tubule, I'm not sure if they give the both option, but the distal tubule was the answer, or distal convoluted tubule was the answer there, or the option was there. And descending loop of Henle, we know that it's going to only allow water to go out, and the urine here will be hypertonic. So the descending loop of Henle option also gets ruled out. So what option we had was that late distal tubule or distal tubule, where this antidiuretic hormone is also not having its effect, or the urine concentration is also going to be very low in here, because here hypertonic, here hypertonic, starting from ascending loop of Henle to the DCT. So the answer here finally was late distal tubule, or if late is not given, but it also can be marked. But if the same question, if they have to repeat the same concept again, they can make it here highest osmolality, or under the influence they can change it to in the absence of this antidiuretic hormone. So take note of this, and comment down what will happen or what will be the answer in the case when there is no influence of antidiuretic hormone. So, as I said earlier, integrated pharma, physio, some patho, and some medicine as well. And there were 3 questions which were asked from this diagram. This was only in one diagram, but to simplify, I kept the physiology portion separate and the patho, pharma, medicine separate. This was all for this video. I have this file here. You can get this file from my Telegram channel. I have kept the link in the description. Also join my Telegram channel, like this video, share it with your friends, and subscribe to my channel for more such content. Here I'll be posting more of my notes. This is from my notes, and it's going to be helpful, and you can learn pretty easily things, and it's not that hard to remember these things when we have such diagrams here. And also the pharma integration which I mentioned, it's already here I have, and also about the mountain sickness I have mentioned things here. Right, thank you for watching this, and all the best for your FMGE journey.